Welcome to a Talk Tools webinar. Today's presentation is Prevention of Orofacial Myofunctional Disorders in the 0 to 3 population with Talk Tools instructor Robin Merkel-Walsh. We're going to get things started here in just a few minutes, but real quick with a show of hands, if you can please confirm that you can see me and hear me. There's a little hand icon on your webinar control panel. And I see those hands going up. Thank you. But if this is your first Talk Tools webinar, there are two important features that I'd like to point out. We do have a questions tab and a handouts tab. So at the end of the presentation, we'll have a live Q&A with Robin. So any questions that you have for her, please submit that through the questions tab. And her handouts for today's presentation can be found under the handouts tab, available for you to download. Finally, all participants will receive a follow-up email within 1 to 2 business days with a link to today's recording. Please keep in mind that all Talk Tools webinars have an expiration of 30 days after the live broadcast date. So 30 days after today, this recording will no longer be available to view. Also in the email is your certificate of completion, the handouts, and the required course evaluation survey. This is required to receive credit for this course. Additionally, if you need ASHA CEUs, please submit your ASHA number in this survey. It's super important to get that survey turned in as soon as possible. We do have deadlines to file for all of our courses, so if you submit that survey after the deadline, we cannot go back and report CEUs for you for this class. So if you haven't received this email within 2 business days, please contact us at continuingeducation@talktools.com. So thank you again for joining us, and please enjoy your time with Robin.
Thank you, Lisa. Okay, hello everyone. Lisa, just let me know if you can see me and hear me before I get started.
Yep, everything looks good. I see your slides.
Okay.
You might want to put it in. Yeah, there you go.
Yeah, yep, it's always a little delayed when we're on here. Okay, so good afternoon. I'm live from New Jersey. Today is the first day since March 13th that our state has opened up for retail shopping and outdoor dining. So it's a pretty exciting day here. I don't think I'm ready to do retail shopping or outdoor dining yet, but I know a lot of my friends and neighbors are really excited about this. Thank you for joining me. This is a webinar that I'm very passionate about, in being a speech pathologist who specializes in oral motor, feeding, and orofacial myofunctional disorders. This is a class that is backed by popular demand, and I'm so happy to teach it again because I feel it's a really critical topic for anyone who is working with orofacial myology, feeding, swallowing, low tone, dysarthria, and even if you're not, and that's not your area of interest, this is really good information for you to know so you can identify some problems early on. Even if you're a parent, many therapists have told me that this topic has helped them with their own children at home. So let's get started. ASHA disclosure statement. I'm a member of the Talk Tools Professional Enhancement Team, and I do receive honorariums for lecturing in products that I've developed. I will be discussing methods that aren't my own, and of course, citing them. Non-financially, I'm the board chair of the Oral Motor Institute. I'm a former board member of the New Jersey Speech and Hearing Association, and I'm currently my last few weeks as the co-chair for NJISH's private practice committee. I also volunteer as the CE provider manager for Marshalla and Associates, Speech and Language. I'm a member of the NJEA, NJISH, the IAOM, ASPA, the Ankle Glossia Body Workers, and ICAP. So that's the technical stuff, but who am I and why am I talking about this? I am primarily a clinician. A lot of people know my name because of books I write or courses I teach, but I'm a clinician that works in the public school system. I'm entering my 26th year. I finally get that 25-year fulfilled longevity. I am working right now with autism, multiply disabled classrooms, but primarily grades 1 through 2. So started my career in the general education setting, and all my kids were either inclusion kids or articulation kids. And that's when I really developed this interest in orofacial myology, seeing how many of my students at school had abnormalities of the craniofacial structure, or dental issues, or soft tissue issues, low tone, things of this nature. And then for a big chunk of my career, I took a big interest in autism and special populations, and the prevalence of oral motor feeding and orofacial myofunctional disorders in that population, and why we should not ignore it, and why it's a really important thing to address. Because what I was seeing as a school-based speech pathologist in preschool, I was working in the preschool for like 13 years, is that children were coming into school still on a bottle, not eating solid foods, a lot of noxious oral habits such as pica or nail biting, or still using a pacifier. And no one was really educating the parents as to why these things were inappropriate, or what it could mean in terms of having an orofacial myofunctional disorder or a feeding disorder. So anything that I've authored or lectured on comes from a place of passion, of a challenge that I've met as a clinician. And not only am I a clinician in that school-based population, but I've also had a private practice for 24 years. I started working under someone else, then I did home care, then I rented for someone else. And for about the past decade, I've been in my own solo practice. And it's been very interesting with the pandemic, moving into teletherapy. I just did a blog on our website if you want to take a look at it. And what's seemingly impossible, doing oral motor and orofacial myofunctional therapy, how it can be successful in telepractice as well. And finally, I consider myself an advocate as board chair of the Oral Motor Institute. Since 2007, I've been battling the myths of oral motor not being evidence-based. I do a lot of advocacy work through different organizations, and just a strong presence in social media in terms of helping parents get insurance reimbursement, helping parents get services from the schools, and also just in general for the children to get the right care that they need. So why I'm doing this webinar is to bring confusion to a place of clarity. There's a lot of talk in the myofunctional world about myofunctional therapy with babies, or myofunctional therapy on your own, do-it-yourself kits, things of this nature. And what we'll learn in this class today is orofacial myofunctional therapy was always designed or intended for older children that could respond to, look at me, say what I say, imitate what I'm doing, self-monitor. And because of that reason, people who were training in orofacial myology weren't really being trained to do anything with this really young population, or discussing how to prevent different issues. And there was this big separation between feeding therapy and orofacial myofunctional therapy. So I taught a webinar on that, and we're going to go over some of that information today as well. Also important and passionate to me is the difference between orofacial myofunctional therapy versus orofacial myofunctional therapist. That's a big confusion as well. There is not a license for an orofacial myofunctional therapist. The therapy as a treatment modality falls under the scope of practice of speech language pathologists, and it's in the policies of the ADHA, which is for registered dental hygienists. And I learned today that more policies were being passed on that for the RDHs, which is very exciting for them. And then there are parts of orofacial myology that we will learn today is in the wheelhouse or the scope of practice of supportive professionals such as occupational therapists, physical therapists, chiropractors, etc. So our learner outcomes are to be able to identify at least 3 signs and symptoms of oral dysfunction in the 0 to 3 population, to be able to list the 3 ways to assist children ages 0 to 3 to follow typical oral motor developmental norms, and also to list at least 2 oral motor specialist approved mouth tools that promote desirable mouth development. So let's get started. What is an orofacial myofunctional disorder? American Speech and Language and Hearing Association defines an OMD are patterns involving oral and orofacial musculature that interfere with the normal growth, development, and function of the orofacial structures or call attention to themselves. OMDs can be found in children, adolescents, and adults. They can co-occur with a variety of speech and swallowing disorders and may reflect the interplay of learned behavior, physical, structural variables, genetic, and environmental factors, okay? So the American Speech and Hearing Association actually has a portal. They have a lot of different topics, and they have one for the public, and then they have one for speech pathologists to take a look at, which is very detailed. And I was pulled into a task force. Mary Billings was asked to assist with this document, former IAOM president, and that's the International Association of Orofacial Myology, if you haven't heard of it before. And Mary brought together her own team consisting of Christy Gatto, who's the author of one of the best orofacial myology structure books, and Linda D'Onofrio, who is a very well-known speech pathologist who specializes in OMDs and runs the Oral Myofunctional Study Group on Facebook, and Nicole Archambault, who is a speech pathologist with a specialized interest in airway and tongue tie. So together, we helped with some of the submissions to this portal. And in the portal, we list some of the signs and symptoms of an OMD. Now, remember, where orofacial myofunctional therapy may be driven for children aged 4, 5, and up, that doesn't mean we can't recognize the early signs and symptoms and be working towards improving that. Some of the signs and symptoms are an abnormal resting posture, tethered oral tissue, a tongue tie, a lip tie, mouth breathing, dental malocclusion and abnormalities such as crowding of the teeth, overjet, open bite, spaces in between the teeth, which are called diastemas, palatine tori, which can be present and a sign of issues, articulation problems. We see this as children 2, 3 years old are developing language. They can be really have a limited phonemic inventory, abnormal swallowing patterns, sleep issues, high end or narrow palate. That lets us know the tongue is not resting properly. Airway obstruction, that would be enlarged tonsils, enlarged adenoids, narrow airways of the nose, deviated septum would fall in that category. Picky eating or self-limiting diets. I must say to a parent, at least 5 times a week, whether it's my current clients or ones I'm evaluating or parents of students, 0 to 3-year-olds don't wake up one day and say, you know what I'm going to really do to agitate my mom? I'm just not going to eat. It just doesn't work that way. There can be behavioral underpinnings in picky eating and self-limited diets, but there's usually always a sensory or a physical cause of why that's happening, whether it be silent reflux or a tongue tie. We have to get to the bottom of why that child's a picky eater. Drooling, gum disease, we'll see this in older patients with OMDs, and noxious oral habits, fingernail biting, gum sucking, and also bruxism, dental grinding is also a sign and symptom of an OMD. So in 0 to 3 specifically, what would we see? Well, the first one is mouth breathing and snoring. If there's one thing that I learned many things in my training to become a certified orofacial myologist, is that airway is everything. That was the theme of the 2019 IAOM convention. And sadly, a lot of pediatricians don't really pay much attention to that in babies. They're not asking their patients, is there snoring? But if you're seeing a young baby with dark circles under the eyes and deep creases under the eyes, and parents are complaining up so many times in the night, you really want to investigate and ask, is that baby snoring? Because snoring in any human is really never normal. It's a sign of upper airway resistance or possible sleep apnea. And especially in our babies, when we have to worry about SIDS, we really need to ask about sleep. Breastfeeding issues, babies born and not able to latch, and moms are getting really frustrated. Maybe the doctor is saying, just switch to formula, your baby's not gaining weight. Many times this can be a sign and symptom of a tongue tie, a lip tie, buccal ties, or other feeding challenges. So lactation consultant, really important there, IBCLC, to figure out what is happening between the baby and the mom as a dyad, to try to chip away at the layers, the complex layers of breastfeeding issues, and figure out what's causing them. Bottle feeding issues. I have a lot of patients that they were okay with breastfeeding, baby was gaining weight, mom might have been a little uncomfortable, but nothing, that she couldn't get through, and she's over maternity leave and she wants to pump and start giving a bottle, and lo and behold, baby can't take the bottle. Bottle teat does not conform to the mouth the way in which the mother's breast does. So if there's an issue such as a tongue tie, or maybe some low tone, or issues with nose breathing, you can have some bottle feeding issues, and that's the first sign of a possible OMD. Poor resting posture. Every time someone has a baby now, I'm looking at the pictures, or the lips closed. Babies should not have a wide open mouth, and they especially shouldn't have the tongue hanging outside the mouth. Another sign and symptom of possible airway, sleeping issues, low tone, all which manifest into an orofacial myofunctional disorder. Another time when kids show up in my office that are having a really hard time is when they can't transition to solids. Now, for example, I see a patient that is still on just like 1 or 2 purees over a year of age. And this patient happens to be tongue-tied, and mom kept complaining, went to the pediatrician, went to the ENT. Everyone said everything's fine. Sometimes kids don't chew till later on, but this child was gagging and vomiting, and that is not normal. So after proper assessment, learned that, yes, the child has oral restriction. Excuse me. The reason they're not transitioning is they can't move the food to the chewing surface. And if they do, by accident, get it there, when it's time to bring it back on top of the tongue blade and prepare for the swallowing phase, they don't have good mobility. And then they start thrusting and gagging and sometimes throwing up. And once a baby has a negative experience, especially when there's multiple negative experiences with food, that's how picky eating habits can develop. That high vaulted palate, very important. Linda D'Onofrio always says the lips are the face's braces and the tongue is the palate's expander. And in utero, that tongue should already be developing a proper resting posture that helps shape the hard palate. And when a baby is born with a really high vaulted palate, you have to wonder, okay, where is the tongue? Where is the tongue resting? Because this can be a really early sign and symptom that something structurally could be off. And failure to thrive, not gaining weight, not having enough food intake can be a sign and symptom. So what's the difference between oral motor and feeding and OMT and myo? Well, in 0 to 3-year-olds, we're really looking at oral motor development and feeding development. So we're treating problems that we see with protocols that have been around for over 30 years. We're looking at, and we'll discuss, experts such as Lori Overland, Diane Barr, Morrison Klein, Deborah Beckman. We are having a very deep understanding of normal development in order to fill in the gaps. And then once children are 4 and over, they can start engaging a little more, looking in the mirror, imitating movement, doing more volitional tasks. So that transition, and even in oral motor and feeding therapy, Lori and I have organized our books that we've written together, Sensory Motor Approach to Feeding and Functional Assessment and Remediation of Tethered Oral Tissue, from passive to active. So oral motor and feeding therapy can be very passive, where OMT is very active. And anything we use for 0 to 3 can also be used with children with cognitive impairments and special needs, using a lot of these techniques on my patients and students with a diagnosis of autism or a diagnosis of Down syndrome. These issues should never be ignored. It's just how we are going to treat the presenting problem. So you can have an orofacial myofunctional disorder from 0 to death, but the way we treat it would be a little different. So in 2019, Linda D'Onofrio wrote this amazing research paper published in a journal, and it was called Oral Dysfunction as a Cause of Malocclusion. And really important to look at, this was a narrative review, searching the current research. And what she found is that malocclusions and their acquired craniofacial dysmorphology are the result of chronic oral dysfunction, and that's starting in infancy, okay? So if you have these issues, if your airway is compromised and you have to breathe through your mouth, that is going to change your structure. Or if you have tethered oral tissue and your tongue is too low in the mouth as an infant and the palate never drops down and gets a good lingual palatal seal, that's going to cause differential dental eruption and malocclusions. And in order to achieve long-term stability in the face, there is a need to understand the underlying pathology. So even though orthodontic consultations are generally recommended beginning at age 7, we can see a lot of these dysmorphic changes much earlier than that. And now with the movement of airway dentistry and orthodontics, they are working even with toddlers with things like the infant trainer. It's an orthodontic removable exercise device to help with palatal expansion. And this is where the gray areas come in terms of calling that myofunctional therapy with 0 to 3. Yes, the goal is to help an OMD, but when you really think about what some of these devices are doing is if you're developing jaw strength and proper mastication, this in itself is going to help a lot. So in 2017, this was born, another collaborative project between myself, Mary Billings, Linda D'Onofrio, and Christy Gatto. What we were working on is assisting with the ASHA 2018 coding manual and the arguments that some of these dental codes, can they or could they not be used by speech pathologists? And Linda had given a wonderful presentation at ASHA on the differences of and the similarities and differences of orofacial myofunctional therapy and pediatric feeding therapy. And I came up with this infographic in a course that I gave through Talk Tools called Oral OMDs versus Pediatric Feeding, What's the Buzz About? And that's what those little bugs are there, the bee and the fly. And then Diane Barr had me in 2018 take that course and write it as a narrative blog. So orofacial myofunctional therapy, our goals are drooling, digit habits, oral resting posture, bruxism, tongue thrusting, articulation, whereas in pediatric feeding therapy, we also work on intake modifications, self-limited diets, sensory motor dysfunction, hydration, reducing the risks of aspiration, suck training, texture considerations, and choking risks. And then there's that overlap, okay? And this is where scopes of practice can get gray between speech pathologists, OTs, physical therapists, RDHs in these two different diagnoses, because for both feeding and OMT, we're working on range of motion of the cheeks, lips, and tongue and jaw. We work on bolus motility, the ability to move food from center to side and across the midline, dissociation of the jaw, lips, and tongue, jaw grading, mastication skills, strengthening of the orofacial complex, the speed in which oral transit time occurs. That's also a big part when you're doing the oral phase of swallowing in myofunctional therapy. We might be looking at orofacial hypotonia in both therapies, dysarthria, respiration issues, labial movements, lingual movements, and those similarities go on and on. So Sandra Holtzman had a really nice quote in one of her blogs, and it was right around the same time in 2018 that I was doing my blog. And she said, the word feeding is aptly applied to infants and others that are unable to feed themselves, including adults who have serious feeding and swallowing issues. This related area is not within the scope of orofacial myologists. In fact, it may not even be within the scope of practice for speech pathologists who lack the experience with specific training for feeding. So yes, feeding therapy is in the SLP's wheelhouse, but what Sandra is saying is that if you don't have specific training in feeding, you can't just have training in orofacial myology and then think that you're a feeding therapist, and vice versa. I think what makes me well-rounded in what I do is that I was trained first in feeding therapy. Lori Overland was one of the first courses I ever took in my professional career. And then I also got very interested in orofacial myology like 2 years later, working in the public school, and I was seeking all CE areas in these two topics. So I was seeing Roberta Pierce and Deborah Beckman and Lori Overland and Diane Barr and Shar Beauchart and Pam Marshala and a lot of therapists who were practicing in both those arenas. So let's make a comparison, okay? In feeding therapy, it can be passive, requiring no volitional execution of motor skills, but rather a motor response that occurs with the superimposed therapy. So for example, if I take my Sensi tool and I put on a chew tip, and depending, on the patient's age, it could be a very small one for an infant, it could be a larger one for a child. But when I put this at the molar ridge, I'm superimposing tongue lateralization because that's a neurological response. So I'm not saying open your mouth and put your tooth to your molar. I'm using sensory motor cueing to superimpose the response that I want, okay? Pediatric feeding therapy is based on normal oral sensory motor development and task analysis of the pre-feeding skills that's needed for a safe and effective nutritive feeding. This is all described in detail in a sensory motor approach to feeding, a book I wrote with my dear friend and mentor, Lori Overland. And what that means is that we task analyze what are the skills that we need to chew. So going back to the wonderful Sensi tool that we just came out with this year, if I put the tool in and the tongue stays low and forward, or if I do a massage and this, baby is 10, 11 months old and they aren't getting a chewing response, I have to say, hey, wait a minute, this child's not safe to eat solids because they don't have tongue lateralization, they don't have adequate strength in the jaw. I have to work on jaw strength, tongue lateralization as goals before I'm going to work on feeding. So pre-feeding therapy is really that oral motor therapy, okay, and developing the skills that are needed based on developmental norms. Pediatric feeding therapy also has nutritional targets and targets optimal weight gain. So often we're working with a nutritionist, and if baby's not accepting enough purees and solids, how are we supplementing that with breast milk or formula? Or supporting that breast milk is best for allergies, for autoimmune regulation, and assisting a parent with the help of an IBCLC for breastfeeding if that's the parental goal. And there are issues that are inhibiting that feeding. Pediatric feeding may involve the oral and pharyngeal phases of swallowing, and that requires a specific skill set. If I think a baby's aspirating, I'm going to send that baby to an outpatient hospital facility where I know that they're dealing with the pharyngeal phase of swallowing. I'm not doing that in my office. It can occur from 0 to 18 and includes breast, bottle, puree, solid, cup, straw, and tube feeding. So speech pathologists that are doing this work, and sometimes it will be an occupational therapist, and of course with breastfeeding, it could be an IBCLC. But according to the Pediatric Dysphagia practice portal, we do have the scope of practice to work on any of these issues, but we need proper training to do so. And finally, a pediatric feeding team can be very complex. It can consist of an IBCLC, a gastroenterologist, an endocrinologist, an allergist, otolaryngologist, also known as an ENT, pulmonologist or respiratory therapist, dietitian, SLP, home health aides, nurses, occupational therapists, and or physical therapists. And there may even be more people on that feeding team. It could be an oral surgeon or a dentist or a periodontist if we're talking about tethered oral tissue that's impacting feeding. In comparison, orofacial myofunctional therapy may overlap, but it has some distinct differences. The first is that it's an active and often requires volitional execution of a motor plan by the client. So we may be teaching oral resting posture, and one of the ways I teach oral resting posture is I talk about keeping the tongue in the house and open your mouth, tongue tip to the spot, raise your tongue to the roof, close the door, close the screen, and practice the resting. So that patient has to be able to do that, where with feeding therapy, I'd be using a lot of these sensory motor tools. This isn't to say I can't use these in myofunctional therapy, but I might be much more direct in saying, I'm putting the tool to your molar, touch it with your tongue. Now I'm going to switch sides. Touch it with your tongue. So it's definitely more active. In OMT, it really requires the patient to know the why of the program. And the patient is actively involved at working on their goals. So why are we here in myofunctional therapy? Because I'm sucking my thumb and I need to stop. Why are you in myofunctional therapy? Because I had a tongue tie and I have to learn how to use my tongue right. Why are you in myofunctional therapy? Because I bite my fingernails and I drool a lot and I don't say all my speech sounds clearly and I want all of that to progress. So we're actually talking to the patients and making them an active decision maker in their therapy program. OMT is also based on abnormal structure, tone, or resting posture, habits, and swallowing. So I always say with orofacial myofunctional therapy, the feeding training should be there too, because feeding is based on normal development and OMT is based on the abnormal manifestations. So it's really important that even though someone specializing in orofacial myology might not be working with babies, you can still learn about that 0 to 3 development. And it can help a lot with recognizing OMDs in older populations. While early signs of OMD can be recognized in infants and toddlers, the start time of orofacial myofunctional therapy varies in the literature. Some say it could start as early as 4. Some of the more traditional teachers in orofacial myology still feel it's closer to 7 or 8 when the treatment should be started. And again, it's because of that self-monitoring process that's required. OMD team is also pretty complex. It can include a pediatrician, physician, speech pathologist, RDH, dentist, orthodontist, airway dentistry, allergist, otolaryngologist, sleep specialist, body workers such as osteopaths, chiropractors, licensed massage therapists, craniosacral therapists, OTPT, and or oral maxillofacial surgeons. So big team there, depending what signs and symptoms are present. If you have tethered oral tissue, you're going to need a surgeon and you may need body work. If there's a lot of bruxism, TMJ, joint pain, which is considered an OMD, you might need to be going to a PT that specializes in jaw work, or a chiropractor or an acupuncturist for pain management. So with that being said, we are going to take a walk through assessment in that 0 to 3 population. We're going to look at the size and shape of the head, the facial features, the body posture, the palatal vault, the frena, oral motor skills, infantile reflexes, oral habits, feeding, and speech. And of course, this is an overview because we only have a little under 2 hours with break and with Q&A. So this is going to be an overview, but we do teach full day classes on this. If you're interested in diving in deeper, we have our TOTS course, which is now being expanded to a 2-day, 1 day on assessment, 1 day on intervention. I have my SMILE program and looking at lists from an orofacial myofunctional approach. I teach a structure class. Lori teaches a 2-day feeding class. So you can get a lot of information in this coursework. So assessment tools for feeding and oral motor dysfunction. We have something I love. Char Beauchart has an orofacial illustration guide, and you can go to Speech Dynamics, which is her website. And this is a downloadable, so just make sure you have enough ink, but it's very reasonably priced. In Talk Tools, when you take our TOTS class, we've developed both a screening tool and a protocol that's available in our book. And we even have access to this online, but we like it to be used after you've taken our courses or have read the book, because then you understand how to do it. And we have it downloadable in Adobe where you can plug in all your information in. We have Lori Overland and Sarah Rosenfeld Johnson's oral motor developmental norms. And believe it or not, I use this a lot in the school system to justify treatment in saying, wow, this child doesn't even have tongue lateralization. That should have been in by 4 to 6 months, a more controlled tongue lateralization. And this kid is 8 and they're still not doing it. Again, understand the normal to diagnose the abnormal. Morris and Klein have a pre-feeding checklist. Diane Barr has a lot of recommendations in her texts. There's the early feeding assessment tool. There's the Bristol breastfeeding assessment tool. There's the Beckman protocol. And there's, of course, also the Hazel Baker tool for tongue tie assessments with breastfeeding babies. So this is a sample of my evaluation form, and the full evaluation forms are available on the Talk Tools website. It's actually under our TOTS class. So you go to the resource area and then you look for course handouts and information. And in the TOTS section, this is part of a sample evaluation form in being able to indicate what problems you're seeing with the craniofacial structure. Is the, facial features normal, where they're all symmetrical, 5 widths and 3 horizontal planes? Is there symmetry in the face, asymmetry? How's the palate looking? Is there a recessed jaw? The profile, all of these different issues that let us know that something is wrong. And then I also like to look at all the different muscles and how the muscles might be affected. So I'll look at, for example, is there good jaw grading for chewing? And if not, what are the muscles that may be affected? Or even something simple as lip closure, you have an open mouth posture and you start feeling for tone and observing tone. Well, if there's weakness in the orbicularis oris, we're going to have a hard time maintaining our closed lips for an appropriate oral rest posture. Who's on this assessment team? We have our medical professionals that are at the core, okay? The pediatrician, the dietitian, maybe ENT, it may be the gastroenterologist. And then we're looking at IBCLC, looking at the dyad, speech, looking at tone and oral functions, which the OT might be doing as well. But OT-PT is also going to look at larger muscle groups. Is there torticollis present? Is there asymmetry in the body? All of these things are very important, especially when we're talking about 0 to 3 and feeding, because if there's weakness in the body, as Lori Overland always says, what you see in the body is what you're going to get in the mouth. So if there's oral motor weakness, we have to have OT-PT look at this patient or student as well, or if you're in early intervention, your client, because you want to find out, well, is there problems with core strength? Is there asymmetry? Is there global hypotonia? All of these things can be impacted. So if you're not familiar with diagnosing in the 0 to 3 population, a lot of that, the structural, I really recommend that you look into that Orofacial illustration guide and also Christy Gatto's Orofacial complex text and pocket guide, because that will help a lot. And this is also taught by the IAOM when you're doing your intro certification class, and it is gone over in coursework by myself, Lori Overland, and Diane Barr. Okay, so why is 0 to 3 so critical? Think about your long-term goals. Everyone wants symmetrical face, okay? Symmetry in the face is actually related to the perception of being beautiful or being handsome. If we analyze some of the facial features of the most highly coveted, beautiful women or handsome men of the world, we figure out that they have very symmetrical facial features. Good dental alignment. No one wants to have to wear braces, expanders, Invisalign. So if we can guide oral facial growth, this is really important. We want articulation to be clear. If we're developing a situation where the tongue tip can't reach the parts of the palate or the back inner part of the molars or properly retract, that's going to affect a lot of speech sounds, because we need good tongue retraction for all our vowels and all our consonants other than TH. So if the tongue oral resting posture is very low and forward, this is going to have a negative impact in the long run on speech clarity. We also want safe and effective swallowing. We don't want our kids choking, gagging, throwing up, not pleasant. Not only could it be very dangerous, but it can lead to self-limited diets and picky eating habits. We need our kids to sleep. 0 to 3, if you have sleep issues this early on, they're only going to manifest. And what happens when we don't get enough sleep? We're just not healthy in general, okay? And parents are often surprised when they say to them, you know, your baby's not supposed to have those dark circles under their eyes. They're a baby. And the parents will say, well, it's hereditary. Why is it hereditary? I'll ask the parents, do you snore? Do you have a deviated septum? Did you have your tonsils out as a child? And almost always, they're going to give me back that information that these are problems they've suffered with their whole life. So if we can identify it really early, we can be preventative. Healthy diet. We don't want kids eating, you know, the Cheez-It cheese doodle diet, or avoiding, you know, meats. Meats is a big one. Meats are more difficult to masticate, form a bolus with. I see a lot of kids that are on these really carb-focused diets, and you know, the pediatricians might not be recognizing it's because they have oral dysfunction and they're not properly handling different textures of solids. And we also want healthy teeth. If kids eat a lot of starchy foods, a lot of sugary foods, if they develop dental malocclusion very early on, it can lead to gum disease and dental caries. So if you're seeing a 3-year-old that the parents like, oh, wow, we went for their first dental visit and I can't believe this kid has a mouth full of cavities, or you see bottle rot in the teeth. This is, you know, really important to pay attention to, because if it starts that early, it's certainly in the long run going to get even worse. And in the 0 to 3-year-old population, let's think about what develops. Resting posture, key to developing that palatal vault, is happening at 0 to 3. The hierarchy of jaw, lip, tongue dissociation, which is very eloquently and described in detail in both Diane Barr's book, Nobody Ever Taught Me or My Mother That, and A Sensory Motor Approach to Feeding, and Pre-Feeding by Morris and Klein. When babies are born, their jaw and tongue are often moving as one unit, and the tongue has a pattern of protrusion, retraction, and tongue cupping to support the breast or bottle for feeding. But it's no coinkydink that lip closure starts to develop and dissociation starts to develop from lip and jaw when spoon feeding is introduced on around 6 months. And then jaw grating and mastication and tongue lateralization starts to develop 7 to 9 months in preparation for solid foods. So these areas, there's a very quick development between 0 to 3 and a lot of different milestones that are occurring. And this isn't something pediatricians are checking for. OMDs are often found when it's really late, like, oh, by 3, you know what, there is some oral dysfunction, he's still gagging and throwing up, or whatever the signs and symptoms may be. And if it would have been checked at the time where it was supposed to be mastered or emergent on a normal scale of things, it could have been helped. In 0 to 3, jaw strength for mastication is developing. Babies go through mouthing and teething and all of those naturally occurring things that help them with jaw strength. These are prerequisites for oral motor, for both feeding and oral placements for speech. So 0 to 3 is jam-packed with oral sensory motor norms that are supposed to be occurring. And that's not all. The oral resting posture and the functions of the orofacial complex are going to influence dental growth. So for example, if you have a baby that's not teething and not munching, those teeth aren't going to come in on time, because it's the teething and the munch chewing and the introduction of foods that's helping those teeth break through the gums. Same with if the baby falls and loses their 2 front baby teeth, and those baby teeth don't come in, those adult teeth don't come in until 5 or 6. This is years where the tongue to spot resting posture and those central incisors being used sort of as a cage for the tongue, it's going to affect what happens to the face and facial growth. And this is from the Breathe Institute out in California. That's Dr. Zarush Zaghi's practice, who is an ENT specializing in airway and tethered oral tissue. When you have a normal pathway of facial development, you're breastfeeding, you transition to all your foods, you're doing mastication in an appropriate way, you're following that hierarchy, you're going to have a normal pathway of facial development. But if you're mouth breathing, or you have a tongue tie, or a tongue thrust with that tongue pushing against the teeth for swallowing, what's going to happen, that high palate, the chin's going to become recessed, and you're going to develop something called long face syndrome. And you can see the difference between this picture on your right versus this picture on your left. So let's take a look. We're going to talk about the function-form balance, okay? So oral resting posture is significant in maintaining the right balance for dental eruption, tonsil and adenoid size, and the formation of the palate. I always thought, well, mouth breathing occurs if your tonsils and adenoids are too big, but there is some school of thought that if you're mouth breathing for another reason, like a deviated septum or a tongue tie, your tonsils and adenoids become over-responsive because your nose filters the air in the turbinates. It won't be too cold or too warm going into the lungs. It takes care of things like pollen and environmental irritants. But when it's going straight into the lungs, the tonsils and adenoids are part of the immune system and they become over-responsive. And then the palatal vault, if the airway is affected and that palatal vault is too high, this is going to push up on the floor of the sinus, and congestion is going to become problematic. So I might have a little bit of fluid in my nose from allergies, but my palate is normal. I have good airway space. It's just going to drain out. But when your sinus is pushed too far up and the floor of the sinus is too high, there's going to be a narrower sinus, and the slightest amount of congestion is going to lead to ear infections and sinusitis. And then this congestion further causes open mouth posture, and that leads to more infections, lingual displacement, differential dental eruption, and subsequent speech and feeding problems. So we have to catch this early. So how do we support that function-form balance? Through help, support, advice, and guidance. The first step in that is, one, knowing the norms, okay, 0 to 3. So at 0 to 3, we look at reflexes, pre-feeding skills, and feeding skills. And this is developed by, as I mentioned before, Sarah Rosenfeld-Johnson and Lori Overland. So we can't go through all the norms. It takes Lori 2 days to do this in her class, and Diane Barr as well. But there are certain milestones I want to bring to your attention in the 0 to 3. In 0 to 3, the fatty sucking pads, lips, tongue, and palate function as a unit for breast and bottle feeding. So if already at 0 to 3, there's some kind of breakdown in that unit, that's a red flag that intervention's needed. At 4 to 6 months, the cup is introduced. Closer to 6 months, we start with pureed foods, and that munch chewing pattern is developing. This is when we want to stop a pacifier. And the reason we want to stop a pacifier here is for 2 reasons. One, psychological attachment. At that age, there are other ways to self-soothe. It could be music, it could be calming lights, it could be smell, like the scent of the mother's clothing, rocking movement. The pacifier should not have to be there anymore to satiate baby between feeds, or sometimes parents just have the habit of every time the baby cries, introducing the pacifier. And the second reason is that this phase, when the munch chewing pattern's developing and we're looking at pre-teething, we want a lot of jaw work and we want a lot of mouthing. And having a pacifier in the mouth can really interfere with that. At 7 to 9 months, this is when the straw can be introduced, not sippy cups. We want to stay, and we'll talk about that in a little while. But this is the age where that lateral tongue reflex is coming under control. Spoon feeding is getting easier. Baby's tongue is able to move from the center to the side and back to the center. And you're getting teething that's happening in this 5 to 9 month old level. So there's really fast mouth development happening in anticipation for solids. Then between 10 and 12 months, we have solids introduced. There is a lot of emergent research now. Parents are really leaning more towards baby-led weaning, where they're giving a lot of table foods early on, and that can be really helpful as well. But at 10 to 12 months, the true suck is developed. It's easy to remove the purees from the spoon now, and that rotary chew pattern. So at 4 to 6 months, baby is, doing just an up and down, but by 10 to 12 months, the tongue becomes integrated and there's more of a rotary pattern. Then at 13 to 15 months, this is the absolute latest, bottles should be weaned because if they can maintain continuous drinking with a cup or with a straw, they don't need a bottle. Breastfeeding is different. Breastfeeding has a positive impact on orofacial development, but bottle feeding can have a negative impact if it's prolonged. 16 to 18 months, purees are no longer the primary source of nutrition. Toddlers are starting to enjoy family meals. By 19 to 24 months, they're able to chew almost all textures. Of course, we're not going to give choke risks like popcorns and grape with skin, but there's that diagonal rotary chewing pattern that's allowing for even meats to be chewed correctly. And then by 3 years of age, the mature swallowing pattern, there shouldn't be any tongue protrusion during the swallow, and we're pretty much in an oral motor place that we have adequate skills for feeding, and we also have adequate oral placement skills for pretty much any speech sound. So by the age of 3, a child should definitely be off the pacifier, drinking through a cup and straw, eating a balanced diet, receiving primary nutrition through solids, off of a bottle. I mean, this should have happened no later than 13 to 15 months, and have the oral motor capacity to make all speech sounds. So yes, this means if you have a 3-year-old that has a terrible lisp, you probably want to look at oral motor skills because something is probably wrong. So breastfeeding, I mentioned before that breast and bottle are different. Breastfeeding into the toddler years will not cause a problem with dentition in the orofacial cavity, but the bottle could. Breastfeeding, according to Catherine Watson-Jenna, world-renowned IBCLC, and Brian Palmer, DDS, it's the best support for the orofacial complex. The breast conforms to the shape of the oral cavity, and breastfeeding can continue as long as the dyad wants or needs. When I first started learning about feeding therapy, they treated breastfeeding just like the bottle, 13 to 15 months, done. It was shameful to do otherwise, and now the World Health Organization and many dentists and breastfeeding specialists have educated us that that's not the fact. So step 2, know the abnormal. Airway and structure, open mouth posture is never normal, especially when it's accompanied by tongue protrusion posture. The tongue outside the mouth. Yes, babies, when they're first born, will play with their tongue and you see some movement. But if 24/7 that baby's mouth is open or there's tongue protrusion, you want to rule out tethered oral tissue and airway dysfunction. Other cautions would be excessive drooling, reflux, torticollis, or laryngeal malacia, which has a very distinctive sound when baby is feeding. There may be very loud clicking of the tongue. All of these are pointing towards a structural abnormality. Size and shape of the head. Does the baby have a flat head? Take a look at the palate as well. You want to look at facial symmetry, overall tone throughout the body, any soft tissue anomalies that you may see, such as a tongue tie, or blisters. A lot of times if there's blisters on the upper lip from breast or bottle feeding, this can be a sign and symptom of an oral restriction. Absent or unresolved reflexes. If you have an 18-month-old baby or toddler at that point that you're putting a bolus to the molar and they're completely turning their head, well, that's rooting, and that should have been started to resolve when spoon feeding was introduced. If babies are refusing food, that's abnormal. Something's wrong either structurally or with their oral phase of swallowing. Global sensory motor challenges, like babies that are too startled by sound or don't like texture, toddlers that are unwilling to play with their hands and touch different things. I often see this paired. Global developmental delays are often going to have oral dysfunction, and babies and toddlers that are really picky with their food and not accepting any new tastes and textures. I get a lot of that in my practice. So we are going to take a quick break, about a 5 or 6 minute break. I will be back I'm on Eastern Standard Time here in the United States. So it's about 4:38. So at about 4:43, I'll be back on. See you in a few. Okay, everyone, I'm back. So knowing about normal and then abnormal. And once again, lot of information, right? So we can't learn in 2 hours how to do this whole evaluation process, but certainly we have some guidelines of what we want to look at. And those charts are in there for you. You'll have them in your handouts. And if you want the full description of these in the feeding book, just as an example, we have them all listed and what the critical stages are at that point in time. And again, taking coursework, Diane Barr, Lori Overland, excellent for learning that. So how can we be proactive? First is by making the appropriate referrals. So if we see any structural or airway concerns, we have 2 routes that we can go. We can go to the ENT, and you want to make sure it's a pediatric ENT that is well versed in the connection between tethered oral tissue or airway complications in babies. But we can also refer if we have a really good dentist, pediatric dentist, or registered dental hygienist that has training in orofacial myology, to look and see what these structural concerns may be and what needs to be done. When we have functional concerns, we want to make the proper referrals to a speech pathologist who specializes in feeding and oral motor, an IBCLC if there's breastfeeding. And then once again, if we're suspecting like global hypotonia and things of this nature, we want OTPT. And I think where the biggest challenge with 0 to 3 is when you're in an early intervention model. Because if you're in the EI model, at least here in the state of New Jersey, there is a whole protocol where first children get direct intervention, like a special ed specialist, and it's a while before speech comes in, or they may get PT, but they're not getting OT yet, or vice versa. So by the time someone who is trained in feeding or orofacial myology comes in, there's already a lot of negative patterns set in. So I think it's really important in everyone that's working in the early intervention setting that they get this basic training. Again, you may not want to specialize in feeding and oral motor, but get yourself a team of professionals that you know who you could refer to. And in your area, it may be an occupational therapist. I know in Canada, excuse me 1 second, I left my water over here and I need it. If you're in Canada, the occupational therapists do more of the feeding therapy than the speech pathologists and the oral motor. So you have to have a good referral team. And then you may see a 0 to 3 patient or an EI that comes through to you as a speech path, or you're an IBCLC, or you're a PT or OT, and you say, you know, there's something more going on here. You want to refer out to the medical, the neurologist, or the developmental pediatrician, because some of these early signs and symptoms of OMD, like picky eating, can also be a sign and symptom of autism. So it may be more global. And I especially think of our 0 to 3 population, our babies with a diagnosis of Down syndrome or CP. They often have a lot of oral motor issues, and everybody's focusing on the development and the receptive language and the health concerns that can come with Down syndrome or CP. And the oral motor is last on the list. And it's very important to be proactive. The cover of our book, The Little Girl with a Diagnosis of Down Syndrome, is my best friend's daughter, Lacey. And it's been amazing teaching classes to show the pictures and the evolution of Lacey and the changes both through oral motor feeding, myofunctional therapy, and orthodontic intervention, and intervention with the ENT to get the tonsils and adenoids removed and get the ear infections under control. She has such a beautiful smile and a beautiful dental alignment, something we often don't see with children with a diagnosis of Down syndrome. So that being proactive and getting the right team of professionals can really help. Being proactive, whether you're an SLP, an OT, a PT, a chiropractor, being an advocate for breastfeeding is really important because breastfed is best for orofacial development. And when we look at Linda D'Onofrio's paper that I talked about at the beginning of the class, okay, which she found in a literature review is really amazing, that breastfed children have less dental malocclusion. They have an inverse correlation to overjet, which is one of the bigger orofacial myofunctional challenges. And guess what? They have wider palates. They have wider intercanine and intermolar width than those children who have not been breastfed. Okay, so we can see that it has this really positive impact on dental facial. I'm just checking here because I see a little flashing up. That's just announcing I'm back. I just want to make sure everybody hears, sees, and everything good is going on there. Sorry about that. So very, very important. Also important in being proactive is valuing of tummy time, okay? And Michelle Emanuel, occupational therapist, has a very big interest in orofacial myofunctional disorders in the 0 to 3 population, especially tongue tie. And tummy time, according to Michelle, develops the muscles, not only in the body, but in the mouth. It prevents motor delays. It prevents plagiocephaly, which is flattening of the head. Remember I told you before to look at that. We want to see if that's going on, and it can assist with torticollis. Now, there are some different theories on this. Lately, I've been talking to a local PT that I work with a lot that does a lot of Mendelssohn approach for PT, and talking about the use of tummy time being very important, but to be looking at other factors as well. For example, if a baby's really weak on one side, there are other areas of PT that are needed, just not tummy time alone. But tummy time has actually been around since the 1970s. And what happened was, and this also ties into tongue tie as well, no pun intended there, but in the 1970s is when Johnson & Johnson invented baby formula, and it was the women's work movement in the late 60s and the early 70s, and women were having babies and going to work. So they needed to feed their baby when they were at work. And it wasn't really about pumping back then. It was about using formula. So when that happened, and there also was concerns about SIDS, the babies were, one, not getting the value in orofacial development with the orofacial growth from breastfeeding, but now they were being placed on their backs all the time and getting that plagiocephaly. So it's a very interesting time, because when I was a child, you didn't get braces till high school, and everyone I went to high school with had braces. I was actually angry that I didn't have them, and I ended up needing them as an adult and going through 3 revisions, because my whole life this is the way my dental alignment was. But it makes you think about, well, in the 70s we were on our back, we were having formula through a bottle, and you get 18 years later, a bunch of individuals who are having a lot of difficulty with orofacial growth development and dental malocclusion. Being proactive is looking at structural issues and functional issues and trying to be one step ahead at all times. And this is something we're New Jersey allergies, the pollen count is like from 1 to 10, it's probably 250. It's really, really bad here today. When I came out this morning, my red car was an orange color because of all the yellow pollen. So excuse that. But this is a very common concept with special needs children. If we know that a particular diagnosis is going to potentially lead to possible problems, we try to be one step ahead of the norm. And if we see a baby or a toddler that we see functional issues and structural issues, we should try to be one step ahead of the norm as well. And what this means is that you are always working on the pre-feeding skills for the next stage of feeding. So if the baby is being breast or bottle fed, you want to be working on the pre-feeding skills for spoon and cup. And what does that entail? Working on a lot of lip closure. So for example, I might not have the puree on the spoon yet, but I'm working with the spoon and working on tilting the spoon and getting that lip closure. Once baby's on the spoon, I want to say, hey, what's going to come next? It's going to be straw drinking. I'm going to turn around and say, you know what? I need to work on lip rounding. And let me start using a round tip on my Sensi tool and giving jaw support and stimulating lip rounding with some pre-feeding tasks. And then once that baby is on a straw, I want to make sure I'm getting ready for solids and using the pre-feeding chewing hierarchy. And I showed you the chewing tips, and we also use chewy tools and teething tools to do that. And then when I know solids is coming, and we're on introductory solids, easy to meltables, I want to work on jaw-lick tongue dissociation, because by 3, I want to make sure I get that diagonal rotary chew, that adult chew. So you always have to be one step ahead. And it's really important, once again, children with low tone, diagnosis of Down syndrome, diagnosis of CP, diagnosis of tethered oral tissue, that we really want this proactivity. Another way to be proactive, keep on the norms of when we should wean the pacifier and the bottle. And this was mentioned right in the normal. So at about 4 months, we want to replace the pacifier with mouthing toys. And we want to try different options to soothe the baby, like some white noise or music. Some parents like to diffuse essential oils like chamomile or lavender as a very soothing environment. This is when mobiles come into play, hanging the mobile over the baby's crib. A fan at night can be very soothing, and it's also very good for breathing and air circulation. So we want the baby to have that pacifier out of the mouth, so they can start developing the lip closure and the jaw movements and the tongue lateralization that's to come, that's necessary for the spoon, the cup, the straw, and the solids. And then with the bottle, we can start cup drinking as early as 4 to 6 months and straw drinking 7 to 9 months. This is just an example. This is our paper version of the nosy cups. But of course, this is supervised, okay? You're not just going to give the baby a cup and have at it. But At Talk Tools, we have the Infratrainer, we have the recessed lid cup, all really good. And you want to start introducing, and it could be breast milk in that therapeutic cup. And we want to start by a year to start reducing the amount of formula and breast milk in the bottle so that by 12 to 14 months, we can wean the bottle. We don't have to wean the breastfeeding, but as more solid foods come into play, there'll be less liquid nutrition. But when mom still wants breast milk can be done in a cup or a straw. It doesn't have to be a bottle. So if mom wants to do, 3 years of breast milk to support the immune system and to support orofacial growth, and mom is not home, mom's at work, child's going to daycare or preschool, certainly that breast milk can be presented in the proper drinking vessel. And this brings us to step 4, using the right tools. So in using the right tools, this becomes part of therapeutic feeding, okay? So we're talking about prevention of OMDs in 0 to 3. But remember, we're not doing myofunctional therapy here. We are doing feeding and oral motor therapy. And part of feeding therapy is choosing the right tools. So for example, if we have a baby with a tongue tie or a lip tie, we may need to use nipple shields for mom if there's pain while the baby's going through a possible frenectomy, pre and post-op wound care, pre and post-op neuromuscular reeducation. Bottle feeding, we want to consider the size and shape of the teat to reduce excessive air, okay? Dr. Brown's, for example, is a very popular bottle system, has really nice bottle teat. However, if baby is breastfeeding, in those cases, it's more important, they have all these nipples that are, these teats that are just like the mother's nipple. Well, you have to examine the mother's breast and nipple to know if that's like mom's breast, because women have all different size and shape nipples. So that would be very important if mom is going back and forth between breast and bottle. Spoon, consider more of a flat bowled spoon. Like here, I have the maroon spoon, which I love, has a flat bowl. So if I'm trying to work on drawing the puree off the spoon, I don't want a spoon with a really deep bowl where it's going to be hard for baby to draw the bolus off, okay, if they're having some OMD issues. Forks. We don't want to use forks that are way too big for babies' mouths, okay? I see this all the time. Lori calls it European fork feeding because over in Europe, they use cocktail forks to eat because that's more appropriate for getting the food in the mouth. So the big forks that we use here in the United States are probably not appropriate for anyone. So not only should you use the right small fork, you can also use things like plastic coffee stirrers. One of my favorite things to do is to take the Sensi with this fine tip and I stab the cubes of food so I could place them to the molar. It doesn't necessarily have to be done with a quote unquote fork, okay? Another thing for chewing that's great is using the Kids Me silicone feeder. The mesh ones tend to let a lot of bolus out at one time, but the really small feeders can be great. Cups, avoiding sippy spouts, and I'm going to show you the cups that we should be using, and straws, avoiding two-way valves. You have to remember that anything that you're going to find in a commercial store was developed for the parent, not the child's orofacial development. What do parents want? They want non-spill cups. And I always say in my classes, When I was a kid, I had to sit at the table or a designated area to eat or drink. And yesterday was a perfect example in my house. I had my son, we're finally starting to socialize with close family. So my husband's brother was over, and my sister-in-law with their kids. And I tell them, you're welcome to have snacks. You have to eat them in the kitchen. I go upstairs last night. I find cookie wrappers, crumbs, and juice boxes in the bathroom garbage can. So I know that they brought them upstairs, but and there was a repercussion for that. We were going to lose our phone for the day because that's just not allowed in my house. So when you see these, oh, this is great, commercial cup, it's probably developed for the parent and not oral motor development. Using the right tools will mean in the first 4 to 6 months, if parents want to have a pacifier, it should fit the size and shape of the infant's mouth. You have a preemie baby, for example, you do not want like this really big pacifier. Pacifiers should not be used when the baby's calm. I see this all the time when I go to Disney World a lot. I won't be going this year, but all the time I'll see babies in the stroller, babies totally happy, looking around, smiling, soaking in the environment. Parent picks up the pacifier that's around the baby's neck, boom, puts it in the mouth. Not sure why. We shouldn't have the pacifier in all the time that it's inhibiting progress to mouthing. It should be used at a very bare minimum, and consider the size and shape through the American Dental Association guidelines, and it should never be clipped to the crib, clothing, or stroller for just free use, because then that baby is going to become very dependent on the pacifier. So using the right tools, avoid non-spill straw cups, avoid cups with wide, chewy straws, anything that says sippy cup or non-spill, and anything with a sports bottle top, and that's that pop-up top. And you can see in the pictures, this is your traditional sippy cup, but now if you look at these cups that are being sold in the mainstream, like if you go to Target or Walmart, they're adult cups that have the same exact spout. If you look here, it's not that much different. It's this big, wide-mouthed, square spout that's going to cause that child to suckle. And suckling is the same, similar to the motor pattern that's used for breast and bottle feeding. And if you look at these cups, and if you ever tried to drink them yourself, they make my ears pop. I mean, they are forcing the child to use much stronger of a suckle pattern to bring the liquid up, and that's the two-way valve doing that. These are those sports tops. They also encourage tongue thrusting and suckling and not proper drinking. You know, when you have a proper water bottle, what are you doing? The lips are coming forward, creating a seal. You're trapping the water appropriately. Many kids bite on this and you're going to see a lot of jaw movement, and that's not going to help with mouth development. Soft straws with two-way valves often encourage biting, chewing, and forceful tongue thrusting. And I've even seen kids be able to bite these straws off, so then you have a choking risk. Use the right tools. And what are the right tools? Straws that have a block. This is the first straw in the Talk Tools straw kit. When you put this in the liquid, it creates a barrier. A regular straw, the child might stabilize the straw with the tongue blade or bite the straw. When the straw is nice and firm and it has a block, and here's a couple of different examples. We have lip blocks by Talk Tools. The Honey Bear straw cup is a built-in block. This is something different on the bottom that's made by Arcs Therapeutic. But what these all have in common is that lip lock is there that discourages the suckle swallow and the tongue thrusting. Cups with a raised brim. This is an interesting society we have where children are very enticed by coffee. I know this because I have a child, and you know, Starbucks is really like mainstream pop culture, and we have all of these coffee smoothie type drinks, and then they offer the smoothie type drinks without coffee. And kids are very enticed by latte cups and coffee travel cups. So a raised brim really helps with cueing, lip closure, and tongue retraction. So you can find travel mugs that have these raised lids. Our recessed lid cup has a great lid, and it has the availability to either put a straw in or have a quick flow versus a very slow flow. And this is a great cup for babies too, because it teaches them how to drink from a cup on their own with the handles. You don't have to use the sippy cup to do that. The Infotrainer has a very slow flow. That can work as well. And these are all raised lid cups. And when I teach my tongue thrust class or the class on TOTS, we even show how disposable Dixie makes them. Starbucks actually donates some cups to us when we're teaching, which is terrific. And this is really a great way to get jaw, lip, tongue dissociation, lip closure, and tongue retraction to guide mouth development. Step 5, exploration. We want to promote jaw development with the right mouthing toys, not the pacifier. So Diane Barr explains in detail there's 2 types of mouthing. We have non-discriminatory mouthing, and that means I'll mouth my hands, I'll mouth anything I can get in my hands. I'm a baby and I don't know the difference between what I'm allowed to put in my mouth, so I need you to teach me. And then there's discriminatory mouthing, where babies learn that food goes in the mouth and the toys that we give them that are appropriate, or perhaps their hands. So there's a difference between us giving baby a tool versus us using jaw development tools to help with mastication and jaw strength, okay? So if I'm working with a baby like 9 to 12 months and I want to work on some chewing, I may use a chew tool, but when it's shaped like a T, I'm going to be holding it and putting it where I want it placed, okay? As opposed to what you see here, this is a Beckman Tri-Chew, and in the background you see these they're water rings that you put in the freezer, and it eases teething pain. But you'll notice that there's no free edge because baby has a very small mouth. They go to put it in too far, they can gag themselves and cause themselves to vomit. But when the tool is rounded off or triangular, they can safely explore it in their own hands, which is really important. And when I work with any patient, and especially 0 to 3, I remind the parents that the tools aren't toys. Please don't give them to your child to just use all the time, because we want to check them therapeutically and how they're using them. So if you want to learn more about that mouth exploration, I highly recommend the book, Nobody Ever Taught Me or My Mother That, and Diane Barr's course on best practices in feeding and speech with the pediatric population, because she really walks you through a lot of this discriminatory mouthing and non-discriminatory mouthing and a lot of the different tools that can be used. She's got a great class on that. So step 6, fun and functional foods, because the mouth also develops by what we eat. And I see Lisa is sharing here in the question pane. If you're looking for some of these tools that I'm talking about, she's giving you links like to the bite tube set that we have and our straws and all of those fun things, especially Lisa, the honey bear cup we want to share with them because that's a great tool. So food helps the mouth develop and is proactive against OMDs. So Lori Overland says, introduce foods when pre-feeding skills are present. And one of the favorite things that she says and taught me, and I teach all my parents that come into the office, is you want foods that are small enough to handle but big enough to feel. So 2 mistakes that parents make is that they either give minuscule pieces of food for safety where baby can't get organized and has no idea where this food is in the mouth, or they're handing baby really big pieces of food. Even my older patients just being presented with bolus that are way too big. So this is a picture from our feeding book and a nice example of, we have some black olives and we have some strawberries and cucumber, cheese, some very small tomatoes that have been steamed a little bit for a soft skin that I'm able to peel off. And the size of about a Cheerio or a little bigger like a Chex cereal. We want to introduce those, small cubes of food. And you see there, we have a cocktail fork and we have a coffee stirrer that I talked about before. And we want the foods to be fun. Melanie Potic really has done such an amazing job, both in her Facebook accounts and her beautiful books like Adventures in Veggieland. She's just fantastic at this. And we think that babies want bland foods, but they really don't. They want taste just like we want taste. We don't want mashed potatoes that are just plain mashed potatoes. We want them creamy. We want them to have butter and salt and pepper. We might want some garlic in there. I like truffles mashed potatoes. Taste, temperature, and taste can influence the way the child's or the 0 to 3-year-old handles the food. And Melanie has done a great job in thinking about foods that are colorful and fun and have texture. And Lori and Diane have taught us a lot about the safety component and the sensory motor component. So think about eating the rainbow. Babies love avocado, especially if you have some lemon or lime juice to give it that acidic quality. Bright foods like watermelon, strawberry, carrots, exploring sweet versus spicy versus salty versus sour, and using citrus fruits and things like soy sauce or seasoned salt, like an all-natural seasoned salt. And then our textures. When my son was little, he had a lot of food allergies, and I used a lot of quinoa. And if there isn't, now they are. When my son was little, the thought was if you were prone to food allergies, you didn't introduce any of the high allergen foods till 2, and you did slow introduction. And my son did great with that. Now they've kind of reversed it and said, start all those high allergy foods like gluten, eggs, peanuts. I'm often shocked when my patients come in and, baby is 7 months old and already having peanut butter. They've done more research and found if you introduce it early and develop antibodies, there's less likely chance of long-term allergies. The other method worked for my son, but we're always learning. So you can do farro and barley, things with different textures that have a lot of different flavors. Chew, chew, chew. One of the big ways that orofacial development is guided is through the jaw. The jaw is so important, and they didn't talk much about it in my undergraduate or graduate school training. But the more opportunities to, be exposed to different textures of food. And that's where baby-led weaning comes in, and letting babies explore not only the non-edibles for chewing, like some of the tools I showed you before, but also exploring through food. And every culture really has built in those fun and functional early developing foods. Here we have the Gerber graduates. Veggie sticks can be used the same way and are a lot cheaper, and the whole family can enjoy them. We get a lot of these baby and toddler puffs. Corn puffs can be an equal equivalent to that. These are some Korean snacks, Japanese snacks that actually in those cultures, fish is introduced very early. So these have like a shrimp kind of flavor. We have in Israeli culture, bamba, and they're flavored with peanut butter. They're all the kind of same easy to melt textures. And then as baby starts developing skills, we want to work up those textures: cheese, crunchy, chewy, different size and shape. So certain things like a bagel, giving like a 12 to 18-month-olds big chunk of bagel that they can kind of sit there and chew at and mouth explore, where pretzels may be more guided and therapeutic. Little cubes of chicken nuggets. They make really healthy ones now. Cut them up, put them on the baby's high chair tray, all different, crunchy. We want to expose them to all these different textures because that helps with jaw development, and jaw development also guides orofacial growth. Step 7, very important, and I didn't know about this until I became a certified oral facial myologist, is that early health screenings are key. The first oral screening should be after the first tooth comes in and no later than the first birthday. My dentist told me 3 years was the first checkup. Well, if you do a dental visit in that first year, besides for checking for cavities, the dentist can see are they on the right timeline, ruling out tethered oral tissue, and can talk to you about, or the parent, about thumb sucking and pacifier use. Step 8, handling oral habits. This is a controversial one because the American Dental Association talks about praise your child for not sucking. They may do it because they feel insecure, focus on correcting the cause of the anxiety rather than just the thumb sucking. Choosing a method of stopping. There are formalized programs out there. Sandra Holtzman has one, Diana Davidson, Shari Green. The dentist can really help, but at the same time, a lot of these habit elimination programs are not formally done till 3-4 years of age. And by then, you have a lot of impact on dental facial growth. The idea behind this is similar orofacial myology, is children understand the why, but how much damage is done. So ADA says it's okay to end it at 2 to 4. I would say, as a speech pathologist who specializes in feeding and orofacial myology, if you can replace the thumb and the pacifier with the appropriate teething, mouthing toys, a lot of sensory motor foods that we just talked about, and finding other ways to satiate the oral habit, I would say not to wait till 2 to 4 if you can do it with replacement and in a gentler way. So here's some other good resources. That's Sandra Holtzman, Shari Green, Unplugging the Thumb, Pam Marshala. These are great books I find on Amazon. Pacifiers are not forever. We carry David Decides About Thumb Sucking in our catalog. So in review, preventing OMD 0 to 3. 1 is knowing the norms. And remember, you can find out these norms through the books and the different references that I've given you. 2, know the abnormal. That takes training as well, taking courses on infant and pediatric feeding disorders, courses on orofacial myology, dentistry, tethered oral tissue. Step 3, be proactive with those developmental norms. You want to make sure you're ending things like bottle and pacifier at the right time and introducing foods at the right time. 4, using the right tools, avoiding sippy cups and spouted cups, introducing mouthing toys appropriately. Step 5, exploration with the mouth, very important in the 4 to 6 month old range. Step 6, using fun and functional foods, taste, sensory, size, and shape. Step 7, making sure these babies are getting the proper early oral screenings. And 8, handling of the oral habits. Refer to treatment when needed, oral motor therapy, sensory motor therapy, feeding therapy, oral placement therapy, for speech sounds as if the toddler is very unintelligible, outside referrals, dentist, PT, OT, ENT, all of those great professionals we talked about. A complete reference list can be found at this link at the Oral Motor Institute. Also at the Oral Motor Institute in the home page is the Oral Motor Institute statement on orofacial myofunctional disorders in 0 to 4. So if you forget anything that I've said today, I've written a APA style research-based topic paper on OMDs in 0 to 4. And here's some references of all different things I've talked about today: Talk Tools, my website, the Oral Motor Institute, the International Association of Orofacial Myology. And I just ask if you have any questions about CEUs or product information that I can't help you with. If you have a technical therapy-based question, that I can. But all emails can be properly channeled through info@talktools.com. Now, Lisa, I'm going to open up the floor to some questions. We have like 7 or 8 minutes, so I'd like to be able to help everybody.
Absolutely.
And people have questions about today.
Yep, we've already got a few questions in, so we'll just go ahead and get started. First one is from Chrysalin. If you see a child out in public who is older, 1 to 3 years plus, still having a pacifier in their mouth, do you educate the parent about why it is important to discontinue pacifier use? I am tempted, but don't always address it.
No, it's against our code of ethics with ASHA. We're not to impose our professional knowledge or opinions on those who don't ask for it, and that even goes for family and friends. If I'm asked about that topic, I often yell at my husband when we're on vacation because he'll strike up a conversation with a parent, and parent might say, "Oh, I've been trying to get this kid off the pacifier or the bottle. Look at your son. Oh, my wife is a feeding therapist. She's excellent at this." And all of a sudden I'll like get back from the bathroom and I have like a mom's club that's wanting to ask me all these things. So as much as we're tempted, we really can't go up to people and say, you know why you should get that pacifier out? You know how you handle this is that you educate your pediatricians and dentists, make pamphlets about your practice, make pamphlets about what you do. I created with Lori Overland a screening tool for tethered oral tissue. I've offered free workshops to local pediatricians about these topics that we're talking about today, and it's been really helpful. The parents enjoy it a lot, but don't seek them out. Let them come to you. Okay, Lisa, what's next?
And from Divya, are there any good articles you can recommend for parents that educate them on the importance of eliminating the use of pacifiers?
At the Talk Tools website, we have a lot of resources on things of this nature. In addition to Diane Barr's Ages and Stages, she has a blog, and Melanie Poddick does as well. Even Parent Magazine has in their archives, but you have to read it first, because part of the difficulty is when you get these articles that are more based from pediatricians and dentists, like I mentioned, they'll say it's okay for, up till 2 to 4 years of age. We really don't want that. So I always, recommend the speech pathology sites, or even the IAOM has references, and a lot of the orofacial myologists. If you go also to the Oromotor Institute and you look at that reference list, you'll be able to find things in there that can assist you with parents as well.
Thank you. And from Aline, I recently inherited a client who is almost 24 and has open mouth posture at rest, mouths absolutely everything, and drools. Should I refer to ENT? What other therapy strategies can I implement?
I'm going to defer this, because this is a class about prevention and 0 to 3, not doing therapy with adults. For that, I think you should look into possible coursework with the International Association of Orofacial Myology.
Okay, sorry, she said 24 months.
24 months. Okay. So go over that a little more with me, Lisa, again, because I heard 24 years. So I was like, we're going to defer this question. Read it one more time.
So the 24-month-old client has open mouth posture at rest, mouths absolutely everything, and drools. Should she refer the child to ENT, or what other therapy strategies can she implement?
Well, those are red flags of airway and tongue tie. So if you're not well versed in those conditions, what I would do is try to get first a functional assessment with a therapist that has a lot of experience with this, and work with them as a team. They will probably know, you can't just refer to any ENT. A lot of times what happens is I want to refer to an ENT or an oral surgeon that I know, knows about these issues, or airway dentistry. And, parents will go to their trusted family friends. So networking with someone local that has a lot of experience with orofacial myology and pediatric feeding, or even better, both, will be able to link you in their network. Who's a good ENT to send to for this? Who's a good airway focused dentist to send to for this? Because sometimes if you just refer out to an ENT or a dentist, they'll, right away look to do surgery, or, a frenectomy, and pre-op care is just as important as post-op care. So I would definitely, and if, you want to send me an email about where you're located, I can try to link you up with some professionals in your area that can help with that.
All right, thanks, Robin. And from Shannon, do you have some ideas for kids who are making T and D with tongue tipped down? 5-year-old doing this first time to speech therapy.
Okay, this is an articulation question for an older child. This child needs a proper assessment of dentition, palate, swallowing, ruling out any oral restrictions, because by the age of 5, tongue tip elevation develops between 24 and 36 months. So T and D should absolutely be made with the proper placement. So I would, at this age, this child is old enough for an orofacial myofunctional assessment, and I would look for a certified orofacial myologist in your area and make that referral to see what could be going on and what could be wrong. And a lot of times, like, therapists will refer to me, and they will give me all the background data, and then I write like a treatment protocol, and we work together.
All right, well, thank you, Robin. That was the last question that I saw come in.
Okay, terrific. And if you have a question and you forgot to ask it, or you weren't really sure, or you're watching this as a taped version, please feel free to send your questions in to info@TalkTools, and it'd be passed on to me, and I'd be happy to assist you.
We
Thanks,
actually got,
Lisa, for assisting me, and for everyone for joining this webinar. Have a great night.
Okay, thanks, Robin.
Bye.
Bye.